What if you see this image in your ICU? On the monitor, everything is fine, and suddenly this rhythm shows up on your ICU monitor. Is it a VT or a VF, or is it an artifact? Should I give Xylocard? Should I give amiodarone? Should I shock this patient, or cardiovert, or defibrillate? What is the difference exactly? I don't know. How many joules? How many shocks? CPR or not? Epinephrine? How much epinephrine? Sometimes decisions in medical field are as quick as a baseball or a cricket match. The ball is coming and you have to decide within moments what to do. And the actions you take in next 20 seconds will decide what will happen to this patient. So, good evening everyone. I am Dr. Subodh Chaturvedi. I am a consultant cardiac and bariatric anesthesiologist in a small town called as Indore. Now it is not that small as such. I give anesthesia for bariatric surgeries these days. And today I'll be discussing about arrhythmias in ICU. Before we move ahead, I'll give you a couple of disclaimers of my own. First of all, I have no financial disclosure. This is completely pro bono. But I teach professionally. I run a platform called as Clinical Guruji, and we have a website, we have apps and all. But yeah, this is completely these people, these Medflix people invited me very graciously, and I'm honored to accept and humbled to accept this invitation. And let's have a good time and let's go home learning something. So first disclaimer was there is nothing financial between us. Secondly, this is going to be an interactive discussion. I can see your comments and everything, but you can listen to me. I can't listen to you, but I can read your comments. So this is going to be an interactive class, and we will interact through the chat box. So let's have an experiment of chat box. You'll see an image, and you have to tell me who is this guy. Write down. Just you can write the option A, B, C, D. Who's this guy? Like I said, it is an interactive discussion. Unless you write the answer, the story won't move forward. Okay, I got an A. I got a lot of A's. A B also. Nobody is writing him to be my grandfather. Of course, I don't look like him. Good, good, good. So this is how we are going to be interactive. There is a video, Nai. There is video. Good, 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 good. Right. So this guy has nothing to do with ECG. This is my second disclaimer. This guy is Wilfredo Pareto. He was an economist. You can find him on Wikipedia. He gave a very interesting rule. The rule is called as 80-20 rule. 80-20 means whatever you do, whatever you study, whatever you read, 80% of it is useless. Only 20% of what you do or what you study, or in every field of life this rule applies. It is called as the 20-80 rule of Wilfredo Pareto, or the Pareto principle commonly. Only 20% of what you study is useless, and I will try to teach you only the 20% of arrhythmia which will actually come handy in your day-to-day ICU lives. I exactly don't know what the segmentation of audience in this class is, but I'll try to keep it very basic. I'll try to keep it very simple and action-oriented things which we can do. If you are expecting that I'll teach all this into a 45 minutes webinar, I'm really sorry. You'll be saddened to know that nobody can teach ECG in 45 minutes. Not in 45 minutes, not in 450 minutes. It takes years. But still, I'll try to make it worth your time. I won't be teaching any fancy tables about difference between SVT and VT, or is it AVRT and AVNRT. So if there are real pure cardiology guys, I'm really, really sorry. But maybe in some other class, in some other lecture, we'll do a deliberation of half an hour on that only. This class I'll keep to very basics. Let's see how the response comes, then we'll move forward in the next classes. So I'll talk about the things that are real, that are practical, they are applicable in the ICU. So having said that, all my three disclaimers, let's move on to the topic itself. What is rhythm and what is arrhythmia? Now in music, we call rhythm as something which goes in a sequence, like nadin dinna, nadin dinna. The people who are into music, they will know that tal is something which goes in a sequence. Na din din na ta din tin ta, what they call is teen tal kehrwa, whatever. Same way, if everything is going normal in your heart conduction, if it is PQRST, PQRST in a routine normal fashion, then it is normal sinus rhythm. And if it is disturbed by any reason, any means, then it is arrhythmia. So if everything is normal and in order, it is normal sinus rhythm. And if it is not, then it is arrhythmia. But then what is normal? Any ideas? Okay, let's go to the simple diagram of first year MBBS. We have all seen this diagram, this conduction diagram. The rhythm or the impulse, it starts from the sinoatrial node, then it goes to the AV node, then it goes to the bundle of His and Purkinje fibers and spreads all over the heart and conducts the impulse. We all know that. If all this is happening sequentially and as it was intended to be, then it is normal sinus rhythm. I am talking very basic. If it is happening as it was supposed to be, then it is normal sinus rhythm. So what should be a normal sinus rhythm? It should originate from the sinus node, of course. It should originate at regular intervals. It should occur at a rate of like 60 to 100. It should go through the AV node in normal time. It shouldn't be slow in conduction. It should be conducted normally. So let's fire up an ICU monitor, and this looks like a sinus rhythm, doesn't it? Yes. So how do we identify a sinus rhythm on monitor? Very easy. On ECG, it should have isomorphic P waves. What is isomorphic? Ek jaisi, those which look alike. All P waves should look similar. Why? Because they are all originating from the same place. They should occur at regular intervals. The PP interval should be constant. The PR interval, the conduction time, should be normal. It shouldn't be extended. The P is to QRS should be 1:1. That means every P should have a QRS and every QRS has to have a P, and the rate is between 60 to 100. This fulfills all the criteria, hence it is a normal sinus rhythm. If you go on and see, the P waves are isomorphic, regular, and 1:1 ratioed. Every P has a QRS, every QRS has a P, and the P waves are at the same distance, 0, 5, 10, it's normal. What if something is disturbed from this rhythm? Let's say if the rate is increased, everything else is same. Just the rate is 130, everything else is the same. So is it normal sinus rhythm now? No, this is arrhythmia. What arrhythmia it is? It is sinus tachycardia. Still, everything is the same. The PP intervals are constant. The only thing that has changed is rate, and it is normal sinus tachycardia. Now, in this lecture, we will go on a certain roadmap, a particular way of teaching in which we learn. We won't be learning the rhythms according to their origination or their conduction. We will be studying them through a traffic light method. What is traffic light method? The rhythms can be of 3 types. Some rhythms are where you have to stop everything and just treat the patient. Don't do anything else. If you are in an OT, a surgery is going on, just hold everything, ask the surgeon to stop and first treat the rhythm. Some of them are like a little less dangerous. You can wait, but still you have to do something about them. And another set is you can just keep observing them and just keep observing them. You can keep going with the proceedings, just that you have to keep an eye. So we will classify the rhythms accordingly. Every rhythm will show in a particular background. The rhythms which are really dangerous, they will show in red, and so on. So let's again start with an ICU monitor. Let's do a warm-up set, a chota sa basic test. What rhythm is this? I would like you to write in the chat box. What rhythm is going on? Write in the chat box. Yes, this is a sinus rhythm. But by the time you wrote sinus rhythm, something has changed. Can somebody write what has changed? Particularly this thing? This one, this one, this one, this one, this one, this one, this one. What's going on? What is this? What happened? Yes, it was normal sinus rhythm. Right. But what happened? What happened to this sinus rhythm? Something abnormal is going on. Can you notice that? Can you notice that? Can you notice this? What is wrong exactly? Not bradycardia, it's 80. What changed? What changed? Watch closely, watch closely. I have made big graphics for mobile phones also. What went wrong? What went wrong? Just something wrong, something wrong. Somebody write it. Not AF, no, not AF. Yes, missed beat. Somebody wrote missed beat. Yes, arrhythmia, APC. Very good. Skipped beat. Yes. Something wrong has happened and there are some ectopic beats. This beat is not normal. This is an ectopic beat. Right? So what is an ectopic? This was an ectopic beat. What is an ectopic beat? An ectopic is something which is not where it is supposed to be. Something which is not where it is supposed to be. The pregnancy should have happened in the uterus. It has happened in the fallopian tube. It is an ectopic pregnancy. So a beat which is originating from somewhere else where it should not have been is an ectopic beat. We also call ectopic beats as premature complexes. The complexes that arise not from the sinus node but somewhere else. We also call these ectopics as VPCs or APCs depending on their origin, where they are starting from. Or we also call them lovingly ventricular ectopic or atrial ectopic. So ectopic is what? Ectopic is an event in an otherwise normal rhythm that happens aberrantly, that happens strangely. It was not supposed to be there and a beat started. For an example, now there are like 5-6 beats in this ECG. 1, 2, 3, 4, 5, 6 beats actually. Which one of them is an ectopic? Can you write down? Which one of these beats is an ectopic? Which number? First, second, third, fourth, fifth. Which one is an ectopic? Just ignore this one. Ignore this one. Out of these, 1, this 1, 2, 3, 4, 5. Which one is an ectopic? Tell me. Yes, everybody is writing the correct answer. It is the third beat which is ectopic. Which ectopic it was? Is it ventricular ectopic or is it atrial ectopic? Is it APC or is it VPC? Can you tell me? Is it VPC or is it APC? Right, correct. Third beat is ectopic. Everybody is correct. I got all the answers correct. Is it APC or is it VPC? Yeah, 5 is also. Not fifth, this one, but the later one. Yes. Right, so the house is divided ventricular and atrial. Maybe I will call it ventricular ectopic. Why is it ventricular ectopic? How do you say it is VPC only? Why do you say it is VPC? How can you identify a VPC? I'll tell you a very simple rule of identifying VPC. If you can identify it, rather if your nursing staff comes and says, sir, ectopic aa rahi hai, sir, there are ectopic beats, then it is VPC. APCs are very subtle, very innocuous, very missable beats. APCs everybody misses. VPCs are something which are very visible. They are broad complex and they come with a change in SpO2 tracing also. Right. So VPCs are broad complex, very identifiable. They look abnormal. APCs look more or less similar. So if your nursing staff can identify कि sir ectopic आ रहे हैं, then it is VPC. Otherwise it is APC. Now let's see if you can find an ectopic in this rhythm. Is this an ectopic? This was an ectopic. This one? Ectopic? Ectopic beat? Ectopic beat, this one? Again, this one? This one, this one, this one? Now how do you identify an atrial ectopic beat? An atrial ectopic beat looks just like a normal QRS, except that it comes a little earlier and it has a differently shaped P wave. An atrial ectopic looks exactly like a normal sinus beat except for the P wave and the location, right? So this is an APC. The previous one was VPC. How did you identify? Broad QRS, very visible. I mean, anybody can differentiate that this is a normal and this is an abnormal QRS complex. When you come here, it is very difficult to differentiate between these two complexes. They look alike. So atrial ectopics, everybody will miss, and even you can skip them. Even if you don't identify atrial ectopics, it's okay. But VPCs, you need to identify. Right? Why you need to identify VPCs? Because the first golden rule I'll give for today, just write it somewhere, or this lecture will be saved. Watch it again maybe. Just write it somewhere. Be afraid of broad QRS rhythms. All the time. All the broad QRS rhythms are bad. If it is narrow QRS, even if it is SVT, it is better than a broad QRS VT or something. So first golden rule is be afraid of broad QRS rhythm. What exactly is broad QRS, narrow QRS? I'll show you. I'll show you in the heart itself. So this is our good old heart. You know that obviously, but still for the sake of it, this is your right atrium, left atrium, right ventricle, left ventricle. Probably somewhere here is the sinus node. Let me go inside. Somewhere here is the sinus node maybe. And what place is this? What is this place? What is this place? Can somebody write it down for me? What is this place? This place? It's AV node. Fine, fine, fine. So let's draw an imaginary line from above the AV node and below the AV node. Above the AV node, everything is supraventricular. Below the AV node or below this line, everything is ventricular, right? Everything below this line is ventricular. Everything above this line is supraventricular. Supra and ventricular. And between this, there is this AV node. And this AV node acts as what? I don't know what you people call it, but we call it गन्ने का रस बनाने की machine. I don't know what you call it. Maybe sugar cane juice making machine, I don't know. But AV node is exactly like a गन्ने का रस बनाने की machine. What does गन्ने का रस बनाने की machine does? A round thick sugar cane goes in and a narrowed down, पिचका हुआ पतला सा, a narrowed down गन्ना comes out. This AV node does exactly the same thing. It works like a machine. A small gold round P wave goes in and a narrow QRS comes out of this AV node. Just try to remember it this way. The AV node is like this machine. A round P wave goes in and a narrow QRS comes out. So all the rhythms which are going through this node are going to be narrow QRS. Why? Because this node is acting like this गन्ने का रस की machine. And all the rhythms below this line are going to be broad QRS because they are not going through this. Are you getting me? Again, any rhythm which is going through this part, this line, will be narrow QRS. And anything which is not passing from here will be broad QRS. So all your ventricular rhythms will be broad QRS. So what are broad QRS rhythms? Let's say your ventricular rhythms like ventricular tachycardia, ventricular fibrillation, ventricular ectopics, ventricular paced beats, pacemaker beats. So ventricular ectopics, ventricular paced beats, ventricular tachycardia, ventricular fibrillation, idioventricular rhythm, AIVR. Everything is broad QRS. Why? Because it is not passing through the ganne ka ras ki machine. And everything above this, whatever it is, sinus rhythm, sinus tachycardia, atrial tachycardia, supraventricular tachycardia, junctional rhythm, everything is narrow QRS. Why? Because it has to pass through this machine. Are we together? Are we here? Did you get this? Did you get this point what I told you? Everything above this line is supraventricular and narrow QRS. And everything below this line is ventricular or broad QRS. So you should always be wary of broad QRS rhythm. You should worry about VPC. Why? Because VPCs can degenerate very quickly. The moment you see VPC is going on, you have to think of the cause. You have to think what's wrong with this patient. You have to think what's going on with this patient. You have to think of the 5 H's and the 5 T's. Why this patient is throwing up VPCs? Because if these VPCs continue, they will start becoming what? What is this? These are, what is this? Can somebody write down? This is a ventricular couplet. Jaise, like Urdu sher is also called as couplet because it has 2 sentences. There are 2 VPCs. These are couplets. So if VPCs are ignored, they can become into couplets or even triplets. These are triplets. 3 VPCs together. How do you identify it as VPC? It is very identifiable. Broad QRS totally different looking than your normal sinus beat. Anybody can identify VPC. In fact, the diagnosis is if you can identify, then it is VPC only. So VPCs are very identifiable. If they are in patterns of 3, then they are triplets. If they are in patterns of 2s, they are couplets. So if you ignore couplets for very long, what will happen? Because couplets are occurring because of a reason. Did you see when it was simple ectopic, they were green, now couplets were orange, and if these couplets are allowed to occur, they will turn into what? What is this? What is this? Tell me, what is this? What rhythm is this? The couplets have disintegrated into what? And it has become a red rhythm in our traffic light system. What is this rhythm? Tell me. Write down. Yes, it is a VT. It is a ventricular tachycardia. How did you identify? It is broad QRS and regular. Anything that is a tachycardia and broad QRS and regular, always worry about ventricular tachycardia. It is a red rhythm. It has to be treated immediately. Something has to be done. Stop everything. Ignore other patients and treat this one. This is ventricular tachycardia. Now I'll put a poll for you to write down in chat box. You have to tell me what is the first thing you will do. Choose from these options. Write down. So most of them are defibrillating, lignocaine, amiodarone, CPR, none of the above. Do you know what is my answer? I agree with this one. I just missed it. The name. So many people are writing exactly correct answers. That's so good. Wonderful. So next class will be a little upgraded one. Fine. So I will do none of the above. I will check the pulse. If the patient is stable, I will go for medication. If the patient is unstable, I'll go for something else. Only 2 things you need to decide in the ICU. A, can this rhythm kill my patient? And B, how should I treat it? Should I give a shock? Should I give medication? If a medication, then which one? Or should I just observe? So you have to decide only on two things. And what we do instead, is it SVT with aberrant conduction? Is it something this, something that? Bhai, leave something for cardiologists, leave something for EP people. All you have to decide is, can my patient die because of this rhythm? If yes, then how should I treat it? Should I shock him? Should I give a medication? Or should I just observe? So the first golden rule was, be afraid of broad QRS complexes. The second golden rule is, every tachycardia causing hemodynamic instability will be shocked. Every tachycardia causing hemodynamic instability, and the keyword here is not shocked. The keyword here is causing hemodynamic instability. You have to have sufficient reason to believe that the hemodynamic instability is because of tachycardia. So every tachycardia causing hemodynamic instability will be shocked. Many of you are answering that vitals are okay, then we will not shock, and if the vitals are bad, we'll shock. That's so good. But then the keyword here is causing. Let's see an example. This is a patient, maybe you can't read the numbers, it's 137/95. He's a patient in sinus rhythm, he is having good vitals, everything is fine. He goes into a tachycardia, probably a supraventricular tachycardia. How do you identify supraventricular tachycardia? It is fast, narrow QRS, no P wave present, regular. A supraventricular tachycardia, he goes into SVT from sinus and his BP drops to 78/44. He becomes hypotensive, he becomes symptomatic, he's having palpitations, he's having confusions, he's kind of getting drowsy, hi mujhe kya ho raha hai? He needs to be shocked. Because the tachycardia is causing the instability. Right. And the other thing, maybe a patient is in sepsis in your ICU, already in sinus tachycardia with a BP of 90/63, and he goes into atrial fibrillation and his BP drops to 80/49. Of course there is a hypotension, but probably this tachycardia isn't causing the hemodynamic crash. He was already bad. The tachycardia has just pushed him far. Maybe you can avoid shocking this patient. Are you getting my point? What I'm trying to explain is that you have to have reasonable cause to believe that the tachycardia was the reason of his hemodynamic instability. Probably he was way better before the tachycardia. So if the tachycardia has caused instability, we will shock it. If it is a stable tachycardia, then we will go for, like Durgesh says, we'll go for diltiazem. And yes, if the patient is already unstable and in VTEC, we will definitely give shock. This is for the things which happen in front of us. If the patient is like unstable and he is throwing a VT, we have to believe that this instability is because of the VT itself. Right. So even SVT has to be shocked if it is causing hemodynamic instability. So every tachycardia that is causing instability will be shocked, but then the keyword is instability being caused by the tachycardia. Right? I hope I could get the point through. Adenosine, yes, everything can be done. What is the disadvantage of shocking this patient? Sir, no, there is no disadvantage of shocking this patient, but maybe there is no added advantage of shocking this patient. We can shock it. I have seen people shocking bradycardias. I have seen people shocking asystole. So there is no harm in shocking this patient, but remember, every shock causes myocardial dysfunction also. Right? Everything comes with a cost. In medicine, there are trade-offs. There is no solution. You have to exchange something. Right. So let's go further. If it is a pulseless VT or a ventricular fibrillation, it has to be defibrillated. If it is stable VT, or maybe if it is SVT, then SVT needs to be cardioverted. This cardioversion versus defibrillation is kind of beyond the scope of this lecture, but If it is supraventricular tachycardia, a regular rhythm, then it needs to be cardioverted. What is cardioversion? The same defibrillator, it pinpoints the QRS complexes and gives the shock exactly at that pinpoint. So that is called as cardioversion, and defibrillation is just give a shock. Don't think where the shock is exactly falling. Right. So if you want to cardiovert, maybe you can start with 100 joules. So if it is a pulseless VT or if it is a VF, it needs to be defibrillated. If it is a stable VT or SVT, it needs to be. What if we don't shock a VT? What will happen? I mean, we didn't shock a couplet and eventually it landed into a ventricular tachycardia. But even if we don't even shock a ventricular tachycardia, it will further degenerate into a worse rhythm. And what is this worse rhythm? Of course you can tell me, but I would still be, yeah, synchronized, definitely. I'll still be amused if you write me the answer. What is this rhythm into which this VT has disintegrated? What is the rhythm? Write down. Yes, if we don't shock a VT, it will go into ventricular fibrillation. Push T. Yes, it is a ventricular fibrillation. Ventricular fibrillation can be coarse VF, which looks more or less like a VT, just more irregular, more abnormal, or it could be a very fine VF where it is very small waves of ventricular fibrillation. But eventually, a VT untreated most of the times goes into fibrillation, and again this ventricular fibrillation is a red rhythm. Stop everything and treat the patient, and there is no pulse in ventricular fibrillation. So if you have VF on monitor, what will you do? What is your next step? Write down. You have VF on monitor, what is your next step? While I sip a glass of water. Yes, now everybody is right. We will defibrillate a ventricular fibrillation. Of course, we cannot cardiovert it. Amiodarone, no. First and foremost thing, we will defibrillate a patient of VF, and yes, VF will not have a pulse, so there is no point in checking for pulse. So what is the treatment of ventricular fibrillation? You have to defibrillate. Defibrillate with how much joules? Either 200 or 360. 200 in biphasic, 360 in monophasic. No point in remembering. The maximum joules on your machine, you have to give the shock. Forget everything. What is the maximum number of on your machine? Just shock the fibrillation with that much. So ventricular fibrillation has to be treated with either 200 or 360. Of course, depending on if it is monophasic or if it is biphasic, just choose the highest number on your machine and give a shock. What else? What else do we need to do? CPR. Shock, CPR. What else? Shock, CPR, epinephrine. How much epinephrine? Some people call it adrenaline. AHA people call it epinephrine. How much? 1 milligram every 3 to 5 minutes. So now since we have gone through the broad QRS tachycardias, समय कितना हो गया? ठीक है भी तो. Now we have gone through the broad QRS tachycardias. Let's have a small practice. This is a wide QRS tachycardia. The rate I have calculated for you, it is approximately 110. QRS is wide, pulse is present, BP is 110 by 80. What is your drug of choice? Will you shock this patient? Of course I won't shock this patient. The BP is normal, pulse is present. What is your drug of choice? Amio, ligno or shock? Choose. Amiodarone, lignocaine or shock. Broad QRS, pulse present, BP is 110 by 80. What will you give? What will you give in this patient? No, it is not AIVR. Broad QRS with pulse. Choice of drug, amiodarone, amiodarone, amiodarone. So anybody giving amiodarone to this patient might have been the cause of his death. Now again another take home point. ACLS is good, but ACLS is not gospel. ACLS was meant for people who were paramedics, who saw a patient who is like 70 years old and had chest pain and then fell down and probably had a VTVF. ACLS works there. In a hospital ICU, in an emergency unit, in an ER, there are so many things happening, and it is not always good to believe that every broad QRS tachycardia is ventricular tachycardia. So this tachycardia is broad QRS, but then it is not that fast. What is the rate? Maybe 1 big box, 2 big box, 3 big box, 150? What is the rate exactly? Have you seen VTs of 150? No, it was not 150, it was 110. No? The rate was 110. So, have you seen a VT of heart rate 110? No. And the QRS is too broad. It is not broad like VT, it is too broad, it is almost like 200 milliseconds. So yes, it is tachycardia just because it is 110, but it is not VT. The QRS is too broad to be a VT. Think of other things. Think of things like hyperkalemia. Hyperkalemia presents with bradycardia, hyperkalemia presents with tall T waves, but so many times hyperkalemia, too much of potassium, presents with really broad QRS complexes with a rate of maybe more than 100, maybe less than 100. But if it is too broad and not too fast, think about something else, probably hyperkalemia. And what will be your drug of choice now? Not hypo, Harvey. Pulse was present, yes. VT can have a pulse, but still, my point is it is too broad to be a VT and it is too slow to be a VT. VTs are usually 200 plus. Yes, electrolyte. What will be your drug of choice in hyperkalemia? Tell me. What is the drug of choice? Yes, calcium gluconate and soda bicarbonate. Our drug of choices will be sodium bicarbonate and calcium gluconate. But now somebody will ask me, sir, what if it was VT? We don't know. I mean, just by being too broad or a little slow, you cannot say. But then what is the harm in giving soda bicarb and calcium gluconate to somebody? What is the worst that can happen with those two? Maybe his sodium will increase a little. Maybe his bicarb will increase a little. Maybe his CO2 will increase a little. Maybe his bones will become a little stronger with your calcium. Even if you give calcium gluconate and soda bicarb to somebody with VT, there is not much of a harm per se. Like I said, it is against the guidelines, but then ACLS is not everything. ACLS doesn't treat patients absolutely. ACLS doesn't have a 100% result. So yes, we can give these things. Again, think with your own brain. So every broad complex tachycardia is not VT. That is my third golden rule for the day. Sometimes it can be hyperkalemia also. Give calcium and soda. So if you just got these 2-3 things right, beware of broad QRSs. Every broad QRS is not VT, and every rhythm which is causing hemodynamic instability has to be shocked. So let's move on to a few more orange rhythms. We saw that ventricular couplets, ventricular ectopics can degenerate into ventricular tachycardia. What can atrial ectopics degenerate into? This is atrial ectopic. How do you identify it as an atrial ectopic? It looks more or less the same as the previous QRS complex of a normal sinus beat. It is just a little early, it's just a little premature. And there is a compensatory pause, let's not go there. This is an APC. What if we leave APCs be? What will happen to APCs? Where will it go? The APCs will land up into what? The APCs will turn into something different. And I tell you, this is not VT or VF, don't write that. These are all narrow QRSs. But the P waves have gone. and this rhythm has become irregular and irregularly irregular. What is this rhythm? Tell me, tell me, tell me. Or don't tell me, I'll tell you. This is atrial fibrillation. How do you identify an atrial fibrillation? It is narrow QRS, irregular, P wave absent. Hey, by the way, I have made a PDF because see this lecture was already going way beyond the time we planned. So I have made a small PDF. You can ask for this PDF on my WhatsApp. It will be answered by an automatic chatbot. You can just ask for this PDF. I have made a chart of that. Let's go. So atrial fibrillation is narrow QRS and no P wave present, irregularly irregular. What are the most common arrhythmias? Atrial fibrillation. Which one is the most common arrhythmia in ICU? Tell me, is it atrial fibrillation? Well, before you write down, I'll tell you. The most common arrhythmia in ICU is not atrial fibrillation, but it is sinus tachycardia. It is an arrhythmia ultimately. The rate is different. What are the most common causes of sinus tachycardia in an ICU? The patient might be hypovolemic, the patient might be in pain, the patient might be having hypercarbia, or the patient is on ventilator and awake and fighting with the ventilator. So these are technically the most common arrhythmia is sinus tachycardia, but practically when you actually talk about arrhythmias, atrial fibrillation is the most common arrhythmia in the ICU. You should be able to recognize it by irregularly irregular pulse, narrow QRS, P wave absent. If the patient is unstable in atrial fibrillation, we'll have to shock him. If he is stable, then we can think about amiodarone, 150 mg in 100 ml over 20 minutes. So atrial fibrillation was another orange rhythm. It could turn to red if the BP falls, but most of the time it is orange only. It is the most common arrhythmia. Then we can think about another arrhythmia which is orange. It is not that common because it again quickly degenerates into atrial fibrillation, but yes, still atrial flutter is something we should know about. How do you identify atrial flutter? It is narrow QRS, regular, but P waves are present. It is narrow QRS, it is regular. All the QRS complexes are regular interval, and P waves are present, but multiple P waves are present. Like 1, 2, 3 P waves. Here 2 P waves and 1 QRS, 2 P waves, 1 QRS. So they are either 2:1, 3:1, 4:1. Atrial flutter is a regular rhythm. Despite being atrial, it is regular, but narrow QRS and multiple P waves present. The P is to QRS is not in 1:1 ratio. The P waves are multiple. Few more supraventricular arrhythmias. These two. Again, how do we differentiate? They look all the same. This one is narrow QRS, regular, very fast, but P wave is absent. This is a combo of T wave, or this is probably the T wave of previous QRS complex. In this one, there is a P wave, there is a QRS complex, and there is a T wave. Both are supraventricular, but one is SVT and the other one is sinus tachycardia. How do we differentiate? In sinus tachycardia, there is a P wave in front of every QRS complex. In supraventricular tachycardia, there is no P wave. These are just the T waves of the previous QRS complexes. Can you differentiate the two? I think the size is big enough to differentiate. Can you differentiate? Yeah, sawtooth is seen in atrial flutter. So supraventricular tachycardia is very fast, regular, narrow QRS and no P waves visible. Sinus tachycardia is again fast, regular, narrow QRS, but P waves are visible and 1:1. One more difference. Supraventricular tachycardia most of the time goes way beyond 180, 200, 220. SVTs are usually 200. Sinus tachycardia usually in adults doesn't go beyond 140, 150. Sinus tachycardias are in the range of 140, 150, but if you watch if you get to see a tachycardia that is 200 plus, most of the time it is supraventricular tachycardia. Again, I will not go into AVRT and AVNRT. Maybe 5% people will be angry with me in this workshop, but still, most of the people can do with this. If the rate is more than 200 or 180, it is all likelihood SVT. What is your treatment? Adenosine. If it is in the range of 140, 150, P wave present, P is to QRS 1:1, then most likely it is sinus tachycardia. What is the treatment? Treat the cause. Could be pain, could be hypovolemia, could be whatever ventilator related problems. Right. In supraventricular tachycardia, if there is no hemodynamic appeal, just wait and watch. So I have shown you enough rhythms. Now let's have some practice again. Yeah, I'll give the number. What is this rhythm? Write down. What is this rhythm? Write down. In this part, I won't do anything. Just you will keep answering. VT or VF? Yes, it is VF. Why VF? Broad QRS, irregular. Why? Irregular. Broad QRS, irregular. What is this rhythm? Now it is changed. VF change हो गया. अगला, next. What is this rhythm? This one. VF हो गया. This one. There are QRS complexes. They are at regular intervals or irregular intervals. There are P waves. No, there are no P waves. They are fibrillation waves. Probably it is atrial fibrillation. What do you say? Could be, never know. Maybe watch this lecture again. What is this rhythm? What is this rhythm? This somebody will tell me. What is this rhythm? This one. Yeah, AFib ho gaya. Good. Okay, there is a 30 seconds lag between when I say and when I get the answer. What is this one? This one. No, this is not idioventricular. This one. Somebody write down. Yes, it is VT. Yes, it is VT. Somebody write a better answer. This is VT, yeah. But what kind of VT? This is torsa. Now, I belong to a Madhya Pradesh background. I learned Angrezi in college. But, we used to call it torsadis de pointis, but the French call it torsade de point, right? Or torsade de pointis, whatever you call it. The meaning is twisting of points. Like you take a towel and twist it like this. Nichodna, what we call in Hindi. If you take a towel and just twist it, it is just like that. We have taken a regular ventricular tachycardia and just nichod it. This is torsadis de pointis. The treatment is magnesium and whatever. Ultimately, it is ventricular tachycardia. If it is unstable, you have to give shock. When it is stable, then you think we have to give magnesium and we have to give whatever. Right. What is this rhythm? The last rhythm. What is this? What is this rhythm? Tell me. Somebody tell me what is this rhythm? Somebody tell me what is this rhythm, then I'll tell you a story. Right, everybody is writing asystole and everybody is right and everybody is wrong. Why? This is not asystole or asystole as they call it. This is flat line. We don't know if it is asystole or not. We don't know. Why? We need to check. So whenever you see a flat line, again you can take it as a golden rule. Whenever you see a flat line on your monitor, do two things. A, check the leads. Check the leads of ECG, if they are there or not, if they are removed or what. Secondly, increase the gain in amplitude of this thing. Increase the amplitude and check the leads. So many times in a very big hospital, I cannot name it on camera, in a very big hospital, you can't imagine, I have seen people being given CPRs and shocks just because an ECG lead was missing. So two things we'll do. One is we'll check the ECG leads, and secondly, we will increase the gain, increase the amplitude, increase the size of it. There is a button in every monitor. They call it by different names. Why? Because sometimes it can be a very fine ventricular fibrillation which is showing up as a flat line. If you remember, I had shown you a fine ventricular fibrillation also just below the coarse ventricular fibrillation. So if it is a fine ventricular fibrillation, it becomes a shockable rhythm. If it is asystole, it is just CPR and epinephrine. So the treatment is totally 180 degrees. So you increase the gain, increase the amplitude, and then check. If it is still a flat line, lead is in place, even after increasing the gain, it is still flat line, then it is asystole and you have to shock, not shock, if you have to give epinephrine and you have to CPR. CPR, epinephrine in a flat line. If by increasing the gain you realize it is VF, then it is shock, epinephrine, CPR, right? So let's just summarize the three-step process of management. We'll see if the rhythm is slow or is it fast. We'll see if the rhythm is stable or unstable, and we'll see if the QRSs are broad or narrow. If the rhythm is slow, then it is bradycardia. Is it a block? I don't know. If it is a block, then maybe we'll give atropine. Maybe we will give a dopamine drift if atropine is not working. Maybe we'll use pacemaker. This was written for the OT scenarios. Then we'll look for the cause. What is the cause of this bradycardia? We'll check if the rhythm is stable or unstable. Is the rhythm cause of instability? We will jump to cardioversion and defibrillation early in the treatment. Then if the rhythm is stable, then we'll think maybe we should give medication. Which one? Amiodarone, lignocaine, whatever. We'll see if the rhythm is broad or narrow. Is it too broad and less tachy? Think about metabolic causes, think about hyperkalemia. We'll try soda bicarb calcium. Is it stable VT? Maybe we'll think about amiodarone, or maybe xylocaine, or maybe we can think about amiodarone. If it is supraventricular tachycardia, we can give adenosine. Maybe we can think about diltiazem. So I guess that is all for today. I guess my time is way beyond over. I was supposed to go up to like 45 minutes. They said you can go up to 1 hour. So my 1 hour is over from 9:05 to 10:05. So that is all for today. If you want 5-10 minutes more, then you can write continue. I have 2 more slides. Otherwise, we can wind it up. So can I continue for 5 minutes? Yes. Fine. Right. So 5 more minutes. In these 5 minutes, because I haven't taught you bradycardias, so very quickly I'll show you 6 bradycardias in 2 slides, and maybe that will do for your ICU. These are 3 bradycardias. Technically it is 65 or this is 62, but then they are all practically bradycardias. What is the difference? This one is sinus brady. This one is first degree heart block, and this one is junctional brady. Sinus brady, why? Because everything is sinus except for the rate. There is P is to QRS 1:1, all are at regular intervals and narrow QRS, and everything is fine except for the rate being less than 60. This one is Aniket, band kar do isko. This one is first degree heart block. Why? Everything is normal except for the PR interval. except for the PR interval, which is too broad. This one, PR interval is normal. This one, PR interval is too broad. They all look the same. This one, again bradycardia, but no P wave visible. Look very closely. Bradycardia with no P wave. Bradycardia with long PR interval. Bradycardia absolutely normal except for the rate. All these three bradycardias are usually very stable. They don't need to be treated. You have just to wait and watch and observe. Sinus, first degree, junctional. Why junctional? No P wave. Why first degree? Long PR. Why sinus? Everything normal except for rate. These are all bradycardias, but stable bradycardias. You don't need to even give atropine. If the BP is good and everything is fine, the patient is stable, is talking to you, don't give atropine. These are all okay. Problem is the next three, which are the AV nodal blocks. Type 2, Penky back and Mobitz, and complete heart block or third degree heart block. Again, I'll explain. I won't go into detail of that the PR increases and the beat is dropped. No. What is the point if I repeat the same things? If the bradycardias have clumping of QRS complexes, grouping, clumping, 3 are together, then 3 are together, then 3 are together, 3 are together, then 3 are together. I am not even looking at the PR interval. If there is a bradycardia and P waves are more than QRS, of course, because it is a block, and there is grouping of QRS complexes, it is type 2. Let's not go into type 2 Venki back hai ki Mobitz type 2 hai. No. Just if there is grouping of QRS complexes along with bradycardia, then it is second degree heart block. And second degree heart block is bad enough, it has to be treated. You have to involve a cardiologist, you have to tell him that he might need pacing. How do you identify this one? This is a bradycardia which is usually unstable. The patient usually falls in the washroom, he is unconscious, he is an old guy or an old lady who comes with bradycardia with BPs usually increased. The heart rate is typically 30 to 40. Why 30 to 40? Because the ventricular escape rhythm is 30 to 40. Usually it is broad complex. Again, I am saying usually. There are exceptions to everything what I have taught you so far. But then usually 20% of what Wilfred Pareto said. If there is grouping of QRS complexes, it is type 2, it is second degree heart block, it has to be treated. If the heart rate is like 30 to 40, if it is broad QRS and regular bradycardia, broad QRS, regular bradycardia 30 to 40, most likely it is complete heart block, has to be treated. Clumping of QRS, second degree heart block, broad QRS, regular bradycardia, regular broad QRS, 30 to 40 heart rate, it is complete heart block, again has to be treated. Involve a cardiologist. What you can do in an ICU, you can maybe give atropine 0.5 mg stat, or you can try epinephrine infusion or dopamine infusion, not talking about boluses, dopamine infusion or epinephrine infusion, or you can try pacing, transcutaneous through your defibrillator pacing pads, or there is one more good thing, how to do temporary pacing in ICU. There is this 7 French sheath which cardiologist people use, or even anesthesia people use in cardiac for PA sheaths. So if you have a 7.5 French sheath, you can insert it through the jugular and put the pacing lead directly from there. You don't need to wait for a cardiologist to come and take the patient into cath lab if the patient is seriously unstable. Maybe what you can do is just put a jugular line, just put this sheath in jugular and pass a pacing lead, connect it to the pacemaker, check for the complexes. The moment it will touch the right ventricle, just hold it there and it will start pacing. Of course, I mean, the stunts in this program are done by experts, but still that can be done. We used to do that in Metro Hospital, Delhi. I worked as an ICU registrar there. So we used to do that. We put a jugular sheath, 7.5 French sheath, If the patient goes into bradycardias, we can use it for pacing. If the patient goes into LV failure, we can use it for PA catheter.